For everyone with an interest in MASH, or more broadly, steatotic liver disease, Surf's Up, Season 5, Episode 21 of Surfing the MASH Tsunami, our review of the recently upgraded clinical practice guidelines from EASL, EASD, and EASO starts now.
Now, on Surfing the MASH Tsunami.
The aim is to find out liver disease before it is too late. If we can, in some way, catch these people who are completely asymptomatic at an earlier stage of the disease, we can do much more compared to what we can do when they are already cirrhotic.
We are the first guideline, I think, that has an own chapter on prevention, although the chapter is not extensive, but I think that will help from a political perspective to really enforce a healthy lifestyle to prevent even the MASLD tsunami, as you call it.
The disease grows is because people's diets get worse over time. So if this could become part of the process to reverse that trend, then I think you actually start to find one more way to have the ability to slow the rate at which people come into the disease.
It's not often that you get a pre-approval for a guideline of a drug that's not approved in the area that the guideline's been introduced into. So that's dynamic, and that's really dynamic hepatology, and I love that leap of faith.
Earlier this month, over 7,000 hepatology stakeholders convened in Milano for the EASL Congress 2024. This week, join liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and their guests, hepatology researchers and key opinion leaders, Frank Tacke and Elisabetta Bugianesi, as they discuss key elements of the updated clinical practice guidelines presented at the Congress, this week on Surfing the MASH Tsunami.
Remember to stay tuned after this episode for this week's question of the week.
So we're still kind of in our post-EASL phase, but it is joined with what they're calling soccer summer in the U.S., football summer, if you will, in the rest of the world, in that the Copa America and the Euro 24 are going on at once. Congratulations to Frank, whose Germany has made it through to the next round, Frank Tacke, who you will meet in a minute, and to Elisabetta Bugianesi, who you'll meet in the next round, whose team gave, I'm guessing, all of Italy and half of the world a heart attack with how you won yesterday. I've only twice in my life, Elisabetta, seen a match where the last kick won the game. Louise, you know what the other one was, right?
Oh, yeah.
Lucas Moura against Ajax, yeah. And so congratulations to both of you, and congratulations to Louise, since England is through already without having played their third match, although they're getting a lot of heat back home because the team's not playing.
Depends on how you're playing. Not
playing very well, but they've gotten through. And the U.S. won their opening match, so we should all be happy about our football lives. So what we're here to do today, and we may get joined by other folks as we go along, is Louise and I were both forcibly struck by the presentation at EASL about the updated clinical practice guidelines. And we've had questions from listeners who are practitioners. In fact, interestingly enough, not necessarily practitioners in Europe, some from South Asia, some from North America, about the guidelines and how they came to be. So we sent out invitations, and Frank and Elisabetta were able to join us. With that, why don't we get started? Frank and Elisabetta, since you've not been with the podcast before, can you please take a minute or two to tell us a little bit about your work today and your background and how you came to be working in hepatology and steatotic liver disease?
Hi, everyone. I am an hepatologist, full professor of gastroenterologist at the University of Turin in Italy. I started more than 20 years ago, and I was lucky enough to make a PhD in US together with Arthur McCullough, who was one of the first to believe that fatty liver was not so innocent as it was believed at the time. So I started with him and I get involved with MASLD, now what it is called MASLD and former NAFLD, when everybody was involved with viruses and no one was taking into account this poor fatty liver. But since then, we have done a lot of progresses, and I am happy to be here to explain what's the matter with this disease, with this liver disease.
And Elisabetta, if you could tell our audience one thing about you that they might not know if you didn't tell them.
Well, I usually don't tell the audience other than speaking about science. Actually, I'm not an actress and talking about private life. So But I can tell that...
Okay, I can share one for you if you'd like, which is that Stephen Harrison always told me, if you ever speak with Elisabetta Bugianesi, ask her about a recipe for pasta sauce, that she has an amazing pasta sauce recipe.
That's true.
Yeah. Okay. Which she will not be posting on the website. Don't worry about that, everybody. And Elisabetta, we don't ask you to, but thanks. So I think that'll do. Frank Tacke, please, again, take a minute or two and tell everybody your background and how you came to be doing what you're doing.
Yeah, thank you very much, Roger and Louise. My name is Frank Tacke. I'm head of the gastroenterology and hepatology department at the Charité University in Berlin, which is the University Medical Hospital in Berlin, Germany. And I started to become interested into the liver when I was doing my medical doctoral thesis. It was meant to be a thesis about hematology. And then I got in touch with the hepatology department because they provided samples for me and patients. And so this is how I got dragged into hepatology, and that was really long time ago, but I'm very happy that I made the choice. I started in Hanover in Germany with Michael Manns, and then did some postdoc time in the US, and spent a long time in Aachen, which is a city in the west of Germany, and now moved to Berlin about 5 years ago to become chair of the department, which I enjoy very much.
And if there's one thing you could share about yourself that our audience wouldn't know.
Yeah, sometimes people complain and say, well, you're publishing so much, like when you take the time writing. And I remember like at school, I was a part of a newspaper team. And so I think this is when I really liked and enjoy writing. And I remember that we were like two students traveling to the eastern side of Germany, which was the former socialistic part. It happened to be about half a year or 9 months before the wall fell. So it was exciting because we got to meet a lot of people who became very famous afterwards. So they were telling us about like their feelings and kind of their opposition against the socialistic government. And I find that very exciting, being part of history without knowing it or realizing it much later in my life. So this is maybe how I got interested also in publishing and writing.
That's two fantastic stories. Journalist, key opinion leader, and then the story about the East is really great. So thank you very much for that. So with that, we start every episode with a groundbreaker. We ask everybody to share one good thing that happened in the last week, personal or professional. Take your pick. Brave one, go first.
What happened last week? I had 3 days of holidays on a row.
Whoa.
Wow.
Wow. That's it for this year, right, Elisabetta?
Yes.
Yeah, things will come once a year. That's great. Did you just rest, or did you get to do anything interesting with them?
I went to a spa.
Oh, perfect. Perfect. Okay.
That was awesome.
Yeah, wonderful. I think about 10 days ago, it was that we had the summer party with our department, and it was actually the opening game of the EM, of the Euro soccer tournament. And Germany won, so that was a very enjoyable evening, and we had lots of fun. This was probably the best thing that happened. It happened more than a week ago, but I hope it's still okay.
You talked about it last week. You can follow in his shadow. It's fine. Go ahead, Louise.
Yeah, they beat Scotland and my other team, being a Campbell. My father's from Scotland, but they just didn't play very well. But that was the other game that finished on the final kick of the game, realistically. I had a pleasurable 4 days on the South Coast in various different GP practices, taking FibroScan out and checking their high-risk cohorts, which was very exciting. And every single patient who was detected or picked out was very interested about their liver. So the actual engagement in primary care when patients are picked out, being at high risk, is actually overwhelmingly positive. So that was a really nice one, because there's a lot of concern about when we pick people out on historic tests that they won't accept the next stage. But actually, absolutely knocked their socks off and very, very positive. So I can say, yes, people are engaged in knowing if they've got a risk. So that was really interesting to see.
That's great. And I will talk about the podcast for a minute. We've been working over the last month or two to build a Surfing MASH community with a newsletter and invitations to listen to podcasts and a few other things. And we had about 400 people who were tied to us in our mailing list when we started. We've increased that by 50% in the last month. And that's about 25% ahead of where we thought we'd be. So this is my shameless plug. If you're listening to this podcast and you'd like to be part of our community, you can send a note to questions@surfingmash.com, or you can send it, that's probably the easiest thing to do, and we will enter you. It gets you a weekly newsletter. It gets you an invitation to link in and see these podcasts as they're being recorded, which means if you have a question to ask, you get to come online and ask it. And other benefits, office hours with me, and other benefits we'll be talking about as we go along. So I think that's a good thing too. With that, why don't we get started? Basically, as I said, Louise was in the session where you folks discussed CPG, and I was in Philadelphia because I didn't get to go to Milano, and we were texting back and forth, and we were really excited about the session. So when we asked ourselves, what were the things from the meeting that we wanted to make sure to share on follow-up, this was one that came to mind as being really important. And as I say, subsequently, we've gotten questions from people in different parts of the world about, so tell us about these guidelines. I sent you folks 5 questions I'd like to touch on. And first, please go ahead, and then we'll ask questions of each other, and then we'll keep going. First question was easy, I think, which is in 2021, EASL decided that it wanted to trigger this process. I'm wondering what it was that led folks to believe that this was a good time to start, and then how you were able to enroll diabetes and obesity along with us.
Yeah, I think what was really particular about the process is that EASL decided, okay, it's time for an update, which was about 5 years after the launch of the first MASLD guideline at that time in 2016. And they engaged with the other societies involved in the care of individuals affected by steatotic liver disease, which is the diabetologist and the obesity specialist. And I'm really happy that we were able to join forces and bring really the experts from all 3 societies together, at least some of the experts, to come up with recommendations and joint statements and not have different guidelines, like, let's say, a fatal liver disease guideline from the diabetologist, a MASLD guideline from obesity management, but really a joint guideline. I think that's a huge advantage in Europe and in the composition of the panels. So the societies made sure that different types of expertises are represented and also different parts of the world. So we had Elisabetta Bugianesi as an expert from EASL, with Vincent Wong from Hong Kong, Vlad Razio, Sven Frank, Shira Zelbazagi from Israel, Luca Valenti was the representative from the governing board, and Paul Horn was the editorial assistant. From the EASD, we had Michael Roden, who's like one of the leading diabetologists, Fritz Schick, who's an imaging specialist, Hannele Järvinen from Finland, Amalia Gastaldelli from Italy, and from the ESO, the obesity, we had Roberto Vettor as the chair, and Gemma Frübeck and Dror Dicker as panelists. And with this panel of 15 people, which is quite a large panel, on the other hand, it was not enough to really weigh all the evidence. It all underwent a Delphi process with like 46 members, I think, in total from all over the world to really make sure that we come up with the right recommendations. So I think it was really good to have one joint guideline in the end and agree on a process, although it might have taken a bit longer to develop the guidelines. On the other hand, I think, Elisabetta, in the end, it took us about a year, right? So once everything was set up, it was a very, very intense period in which we achieved a lot, at least to my opinion, my memory.
Yes, I must say that we were continuing the previous guideline, the 2016, that were endorsed by 3 societies as well, the Obesity, Diabetes, and Liver Disease Society. And definitely only Europe we have these joint clinical practice guidelines with all these 3 societies. And this is, how can I say, a big advantage, because at the same time we had a large discussion with the endocrinologist, the physiologist, and it was very helpful for us and for them as well, because what we really want to convey is a shared way of managing patients with MASLD and with all the other these metabolic driven disease. And in this sense, these guidelines included for the first time the new nomenclature, MASLD, metabolic dysfunction associated steatotic liver disease, that in some way, can I say, highlighted the metabolic roots of this disease. And it is easier in this way to put in the context of the main non-communicable diseases such as type 2 diabetes, obesity, hypertension, and so on. Also because these patients share the same risk factors and also the same outcome. It's not by chance that people with MASLD die mainly because of cardiovascular causes. But then the liver becomes an important competitor for outcome when fibrosis builds up.
Yeah, and I think what you have to keep in mind, if 3 societies are involved, each society usually has their own process of dealing with evidence, weighing the evidence. So everything that you read in the guideline actually underwent approval by the Delphi panel, get refinement, but also underwent approval by all three societies. So in order to make sure that what we actually recommend is based on evidence, but it's also practicable in daily life, I think that was a really important lesson for us, that the liver needs to be integrated in a more holistic view of the management of cardiometabolic disorders, as Elisabetta has highlighted. That was a very important learning, but in the end, it made the guidelines, I think, really much stronger than just focusing on the small aspect that the liver represents in the whole spectrum of the disease.
That makes tremendous sense to me. In the States, I know they were able to get together on a clinical care pathway that reflected a few different societies, but nothing as ambitious as this. And by the way, they did that before the name change. The name change makes even more sense what you did, because instead of having something called MASLD or NASH, which is out there by itself, it puts steatotic liver disease right at the heart of metabolic dysfunction. So your timing was exquisite and it made a ton of sense. Louise, do you have questions?
Yeah, I did. I thought it was a fantastic document. So congratulations to you all and the teams that did this, because I was saying just before we went online, it's not often that you get a pre-approval for a guideline of a drug that's not approved in the area that the guideline's been introduced into. So that's dynamic, and that's really dynamic hepatology. And I love that leap of faith. So again, congratulations on being that forward-thinking. But the one question that did stick out to me, although we've got the other societies involved, we often talk about how much are they actually looking for MASLD as an underlying co-related condition, because we're obviously assessing for it and looking for it, and we see the co-link with type 2 diabetes and cardiovascular disease, hypertension, hyperlipidemia. Do you think this is going to raise the profile within those specialities and they're going to look more now for it, or are they just going to continue to sort of focus on the endocrine and cardiovascular parts of the disease?
It takes time. Ken Cusi was telling me that it was the same process for kidney complication in type 2 diabetes. In the beginning, no one among the hepatologists was seeing kidney complication, while the nephrologists, on the other hand, were seeing all these end-stage kidney disease from type 2 diabetes. So it is a matter of joining in the middle, because we cannot hide cirrhosis as one of the possible outcome of type 2 diabetes, as well as of the metabolic syndrome, but particularly type 2 diabetes and multiple components of the metabolic syndrome are very important risk factors for the progression to cirrhosis and also for the onset of hepatocellular carcinoma, primary liver cancer. So we shouldn't forget about that.
And I was a bit afraid, like when the name change was introduced, that we would maybe lose the other societies. My experience during working on the guideline was that it's maybe even the opposite, that we have now a clearer pathway, that we have a clear definition that puts the metabolic dysfunction into the center of the disease definition, and that we can say, okay, if you find steatotic liver disease, you have the cardiometabolic risk profile, you exclude relevant consumption of alcohol, then you're there and you need to take this into account. And I think a lot of the recommendations, actually we are the first guideline, I think, that has an own chapter on prevention, although like the chapter is not extensive, but I think that will help from a political perspective to really enforce a healthy lifestyle to prevent even the MASLD tsunami, as you call it in your podcast. But then we have also case finding strategies that are applicable into the general practitioner setting, in the setting of a diabetologist, of an endocrinology practice, of an obesity specialist. And hopefully like those simple pathways or simplified pathways will help to identify cases with advanced fibrosis or at risk steatohepatitis. As Elisabetta has pointed out, this is an important outcome. It needs to be recognized. It needs to be kind of detected early enough in the course of a metabolic disease or metabolic diseases.
Frank, if you see Louise smiling and nodding, it's only because she believes what you just said about as firmly as she believes anything about this disease, right? I know that smile when I see it, yeah.
Yes, I think the prevention, and I think that was the other thing that really impressed me about the documentation, the definitions of where CAP comes in. We can now get people in their 20s and 30s with early steatotic liver disease, that we can really look for prevention, and we can actually take the figures and the metrics on preventing not only steatotic liver disease and reversing it, but also the cardiovascular and the diabetes reduction and things like that. So I just think it's way out there. It's one of the most impressive guidelines that I've seen in years, if any. So yeah, way out there.
Thank you, Louise, also for mentioning, you were bold in putting resmetirom on there. And we really, I think the latest publication application was actually from April, and it went online in June, or maybe even from May. So we really try to be up to date. We try to incorporate we asked the Delphi panel, I think, about the revised resmetirom questions. Elisabetta, it was, I think, mid of May or so, right? It is, I think, the current state of the evidence that we have. And we can say resmetirom, for instance, is not yet approved in Europe. However, the evidence was taken into account. That is also true for the other drugs that are being discussed there, for glucose-lowering drugs, for treatment of cardiometabolic comorbidities. So we try to put all the evidence that was there into consideration. Of course, we needed to make compromises, like from a hepatology perspective. You wish you could have an MRI for everybody on let's say, biannual basis and so on, to make sure that there's no HCC. But we kind of, I think, found a good compromise how to ensure case finding, practicability, and also realistic goals for lifestyle management, for case finding strategies in the practice.
So, Frank, I, like Louise, was terribly impressed about adding resmetirom. I'm even more impressed when I find out that you were able to make adjustments within a month at the end of the process. That's about as fast as I've ever heard anything like that move.
Yeah, because I think we had a very engaged Delphi panel that every recommendation you find in there, even like some of the figures were voted on, and you find in an appendix also the number of how many people consented. So consensus of at least 75% were needed for each recommendation. And if there were good criticism, good comments, we changed it, and then it underwent again the Delphi voting until we really shaped using the swarm intelligence of our panel to get the essence and the most practical recommendations.
As Louise says, and I'm sure we're not the only ones, it's a fantastic document and we congratulate you for it. But I'm even more impressed when I understand how quickly you put it together. I know Delphi panels take time. They're not the fastest thing in the world, although they're remarkably valuable. But to move that quickly, so how did you folks decide who would be on the Delphi panel?
That was not on us to decide. So we were able to make recommendations to the governing boards of ESL, EASD, and EASO. But in the end, the Delphi panel was appointed by the respective societies. And for instance, there were some pathologists on the Delphi panel. There were patient representatives on the Delphi panel. It was people from South America were on the Delphi panel. So of course, we were allowed to recommend some of our colleagues, which we would have loved to have on the core panel, but it was not possible due to limited numbers of people by society. But in the end, they were all appointed officially, with a letter from the different societies to be part of the Delphi panel.
So, for example, how many patient representatives were there? I think that's one of the things we talk about again on this podcast is that patients and allied providers don't really have a voice at the moments that matter most. How many patient representatives were on the panel? Just curious.
It's definitely Achim Kaus, Marco Korenjak, and another, I think it's 3 or 4 patient representatives.
That's 10%.
That were there.
Pretty good.
I think the problem with patient representatives in the field of MASLD is that we do not have a single MASLD patient representation organization. So you have really very strong voices in the field of liver disease who have oftentimes a background in viral hepatitis or oncology. Then we have strong voices in the field of metabolic diseases like type 2 diabetes, obesity. But bringing those people together is actually something I think we will see in the coming years much more than we see it at the moment.
Speaking of that, I had a comment from Mike Patel from the Fatty Liver Alliance, who you all know, which is that he's been telling people that he cured his MAS score and it healed his liver. And then you set the level at 248 and his is 256. So he says now he's not healed anymore. You can't use that story, at least until he gets his level down further. So I was talking with him this morning. I said, so what do you feel about the guidelines? And that was one of his comments as a patient advocate with fatty liver disease. Okay, so Louise, if you don't have any more questions about that, or Elisabetta or Frank, anything you want to say, I'd love to know what you consider the high points. I'm going to go one issue at a time through some of the major topics. What you consider some of the high points on the element about screening, case finding, diagnosis, monitoring. What are some things that people should be paying attention to as they read?
Well, first of all, we have now the first drug approved, so this is a great push to make screening, because one of the objections that has been done before is, yes, we do screening, but then what we are going to do? Now we have the first drug approved, and probably we'll have many more in the next month and year. The second thing is that our pathway for screening the risk of advanced fibrosis is exactly the same of all other societies. So it is very simple, very affordable, and can be done in any kind of health environment. So FIB-4 is the first approach that should be assessed in at-risk people, that is, those with type 2 diabetes, those with obesity, and at least one more cardiometabolic risk factor, or those with elevated liver enzyme, which is the usual reason why patients come to a pathologist. FIB-4 is easy to be calculated, and it's cheap, so it can be done in every country. And we have the same algorithm of the other American Society, Asian Society, and so on. So a two-step approach. If FIB-4 is lower than 1.3, this is a low risk. If FIB-4 is higher than 2.67, this is a high risk and should be referred to a pathologist right away. If we have an intermediate risk, 1.3 to 2.67, then you need a second line assessment that should be done by VCTE, FibroScan. Here we gave two options because of the discussion we had with the hepatologist. So one option, particularly if you have a number, a value to the lower end, so toward the low risk, you can start to manage intensively for at least 1 year and reassess. But if the value of FIB-4 is closer to 2.67, then it is much better to refer this patient to a second line assessment, VCTE, FibroScan, that can be done by a pathologist, but can also be done by the radiologist or whoever has the opportunity to have a FibroScan. And here is the value is equal or higher than 8, then the patient definitely is at risk of developing progressive liver disease and should be referred to a pathologist. This is more or less the same approach that has been also indicated by the EASL Lancet Commission for Liver Disease in Europe. The aim is to find out liver disease before it is too late, so to prevent the occurrence of cirrhosis and the onset of hepatocellular carcinoma. And if we can in some way catch these people who are completely asymptomatic at an earlier stage of the disease, we can do much more compared to what we can do when they are already cirrhotics.
Compared to prior versions of guideline recommendations, at least from EASL, is that liver biopsy is very rarely needed. Of course, it's needed in the clinical trial setting if you really want an accurate staging and grading. Grading means inflammatory activity, or you want to diagnose the steatohepatitis, or if you have differential diagnosis. But we do not need the liver biopsy anymore for this risk assessment. I think that is a major breakthrough also for the individuals affected by MASLD. And as Elisabetta has pointed out, we have so much more evidence now for interventions that work and that can be applied. That refers to lifestyle. It's also bariatric procedures where we have a lot of evidence now that the weight reduction that you achieve actually results in a benefit that is meaningful for the patient outcomes or for liver-related outcomes.
Excellent point. And another thing to commend you folks for is exactly the role that you did not give to biopsy in the process, or things that could be done without biopsy. Because even in the States, shortly after the approval of resmetirom, a investor client had me go out and talk to just basic garden variety lay hepatologists, half of whom were concerned they'd still have to do biopsies. The better job of getting that story out, I think it will make this easier for everybody.
No, I think the other strengths of the document were the dietetics advice, the broad-ranging amount of diets, but just looking at the key points of each area actually were very clear. And for me, they're applicable to any of my clients, irrespective of race or ethnic background or their diet. A lot of my clients don't necessarily have a Mediterranean-style diet. It's more Asian or Indian, and that therefore it can be adapted. And I think that ability within the guidelines to be applicable to lots of other areas, again, is a great win from that document. And the definitions of different causes of steatotic liver disease. So it's not just obesity, it's not just weight weight. It's not just diet. It's very, very clear, and I think it's very helpful for primary care physicians coming into the field, looking at their early diagnosis, particularly obesity and endocrine, again, looking for those. So I think certainly I can see lots of positives for screening and agree that we now have a treatment and we need to be starting to screen.
Yeah, maybe Louise, if I can just re-emphasize what you said. I mean, in the guideline, you find tables with adjusted thresholds, for instance, for the BMI or for waist circumference, which of course has or requires some adaptations to the ethnic background of the individuals. But also in the lifestyle recommendations, there are economic constraints. There are different, let's say, preferences and abilities, for instance, to implement physical activity or certain dietary changes. So an important aspect is to set realistic goals for adjusting the lifestyle, minimizing ultra-processed food or highly processed industrialized food, kind of enrich the diet for vegetables, for proteins, for more healthy diet, but also take into account what is realistic. So set realistic goals also for the weight reduction. I think that's very important, and we try to be as open as possible to the way leading to the success. So like if you compare the different trials on dietary interventions, in the end, the diet quality is important. And in the end, also the weight reduction we know is very important in implementing the lifestyle changes. And this probably needs to be adapted to the individual's preferences and abilities.
And if I may add, although these are guidelines for adult patients, this may also have an impact on children, because if family learn how to eat, how to avoid ultra-processed food or sugar-sweetened beverage, they know that they are detrimental to their child, to their children, then it becomes prevention also for the youngest.
Yeah, which is, I think, an excellent point, because the reason the disease grows is because people's diets get worse over time. So if this could become part of the process to reverse that trend, then I think you actually start to find one more way to have the ability to slow the rate at which people come into the disease. Excellent point. Is there anything particular about the pharmacologic besides what we've already talked about that you'd like to mention?
The pharmacological therapy, I guess, like one important aspect we would like to highlight is that the comorbidities need to be treated in an optimal fashion, in a fashion that considers the liver disease, the activity and the stage of the liver disease. Meaning that, for instance, if you have already type 2 diabetes, we know that combining metformin with GLP-1 receptor agonists like semaglutide or the co-agonists like tirzepatide, which is a GLP-1 receptor agonist, GIP agonist, is very useful because it reduces cardiovascular risk, also in the non-diabetic population, at least in at-risk individuals, and it lowers the weight. It helps people reaching the weight loss goals that you set for the patients. Also to treat dyslipidemia with statins, to use these weight-lowering drugs for obesity treatment is very important to consider when you manage individuals affected by MASLD. I guess the really new thing is that we have for the first time also a specific MASH-targeted therapy that we can recommend, which is resmetirom, if it's locally approved and if it's within the label, which of course we do not know for all healthcare settings at the moment.
And one important thing is, although we do not have specific drug for people with cirrhosis, nevertheless, we can say that some drugs are safe, such as GLP-1 receptor agonists or such as statins, and can and should be given to these patients. I mean, usually diabetologists give insulin to subjects with cirrhosis, but there is no need, unless it is a decompensated cirrhosis, to give insulin. I mean, all the other diabetes drugs, particularly GLP-1 receptor agonists, are good and safe and can improve some of the features that in some ways sustain the further progression and decompensation of cirrhosis.
Yeah, you find in the guideline like a whole range of how to manage pharmacotherapy in end-stage liver disease, which I guess is very important because also like lifestyle recommendations need to be adjusted. So all doses and treatment for the comorbidities need to be considered and possibly adjusted in case of liver cirrhosis, and compensated cirrhosis is usually very safe to continue the drugs with a really cardiometabolic benefit. But of course, in the lifestyle situation, a moderate weight reduction, high protein intake, and then physical activity to maintain muscle mass in an individual affected by liver cirrhosis is very important. And dietary recommendations need to be, of course, adjusted to that. And Elisabetta has already pointed it out how important is to look in this population with cirrhosis for complications of portal hypertension, which would mean, for instance, varices, and complications related to the malignant transformations, so surveillance for hepatocellular carcinoma. And I think, Elisabetta, it was mainly your chapter, like pulling all the evidence together, which is, of course, sometimes difficult to do the ultrasound surveillance for hepatocellular carcinoma, right? We had lots of discussions how to manage that optimally.
Yes, actually, those are the most difficult patients to be screened for hepatocellular carcinoma because the fatty liver is a sort of foggy liver. Mm-hmm. I mean, ultrasound cannot see all the lesions that happen in that liver. And unfortunately, hepatocellular carcinoma is one of the most common complications of these patients, particularly when the patients have also type 2 diabetes, because they are synergic factor to promote the development of primary liver cancer. So we suggest to include also alpha-fetoprotein assessment and in high-risk cases, so with multiple comorbidities where the liver cannot be explored by ultrasound, to use a second-line imaging procedure such as MRI.
I'm not the one to talk about pharmacology, but I think what we hear time and time again from all of the patient organisations and MASLD is this stabilisation of disease to slow down progression. And I think these guidelines set that. If you were new to the field and you were an endocrinologist, by maximising all of the medications around to maximise that patient's care, then we are looking at slowing down progression. We're looking at the best evidence that we've got at the moment. And I think, again, that is a very big strength from the document, is this ability to maximise the treatment that each one of these individuals gets to maintain, slow down progression, and particularly for those that we can reverse. And I think it's very clear. It is, you don't get much later than the changes that Frank and Elisabetta have described within a month of the publication of a guideline to be that key. And I'd hope the rest of the European local societies like NICE for the UK will have to redo theirs, and ours are 2015. I'd like to think that we will utilise these and any future evidence that comes. So I'd love to see it built on, but we'll have to see what the UK decide out of the guidelines.
One of the things I found really impressive about this document was about a year and a half ago, I had a primary care physician in the States describe the process of managing a multi-metabolic comorbid patient as being a little bit like juggling, because you've got 4 things up in the air at once and you got to figure out how to keep them all moving while you treat the patient. I thought this document did a really nice job of putting everything in the context of everything else, so that instead of feeling like you were juggling, you might feel like you could put them next to each other on a table and just sort it out, which I thought was really excellent and to be commended.
I'm just going to say one more point on that. I think the document also really pinpoints for me the role of a potential future role, cardiometabolic nursing, whereby you have nurses within the multi-specialities who bring that management together. So we're not just talking about endocrine nurses or diabetes nurses or hepatology nurses. We're good at hepatology. We're not good at fatty liver. We're better at the end stages when they're in hospital with hepatology complications. So we're moving out towards specialities that all of these areas aren't specialised in currently. But these guidelines allow me, certainly if I was to put a job description together, to say what I can see in that allied health role that can be the coordinator of the patient with these diseases. So those are the advantages that guidelines that are this modern and this related to evidence allow now for that building of those future roles that are going to be intrinsic as to how this disease progresses in its management.
Yeah, absolutely. We also have one chapter that is more like general about treatment, and that applies to pharmacotherapy, to lifestyle changes, to bariatric procedures. How do you monitor treatment success? So which of the markers that we actually measure would indicate to us that we reach this, as you described it, as stabilization or not progressing, stopping the disease, halting the disease, or even reversing some of the phenotypes of the disease? And we try to put all the evidence together, and I like your idea of like putting this a bit in the hands of specialized cardiometabolic hepatological nursing, where kind of specialists that understand the patient needs very well, but also have the holistic view on the different disease phenomena or aspects to actually use the guidelines to promote this concept. I like this very much, although we still have some question marks regarding which are the best markers to monitor. And in the end, at the moment, I guess it's a mixture of several markers that would help us to really really say, okay, we are on the right track, we are succeeding, or we are kind of going downhill. We need to intensify our efforts to manage the individual.
First of all, that's great. And you've actually led into my next question, which is moving towards wrapping up. I was going to ask what has to happen next. And part of that is what kind of adjustments would you like to see in the healthcare system and how we think about it today? And that's one piece of that. And then I'll get to the second half of that question after we answer the first half of that question. Okay. What do you hope to see next, either in terms of people in current roles behaving differently or creating roles to solve the problems that we're addressing here?
Well, I would like to envisage a multidisciplinary team, of course, but also, what can I say, a cardio, liver, kidney, metabolic alliance. We need to fight these non-communicable diseases together, because it is ineffective to study the patient one by one, the hepatologist for the own part and nephrologist for the kidney and hepatologist for the liver. So we should build up an alliance and define together new pathways of management and therapies who really would improve the whole health of the patient, not just one organ or one tissue.
Yeah, I think, Elisabetta, what you described is really a dream, that a patient comes, no matter whether he or she comes to the hepatologist, he gets like a cardiac workout, an endocrine workout, a nutritional counseling, and so on, everything in a multidisciplinary setting. I think it would already be a huge advantage. At the moment, if I think, how do patients end up in my clinic, I would say it's completely random. So sometimes it's like an elevated gamma GT, and the patient then says, well, should I accept that or not? And then maybe the general practitioner says, okay, I refer you to somebody who takes care of that. And sometimes you diagnose a cirrhosis. Sometimes I diagnose an HCC in a non-cirrhotic liver. And sometimes it's a very mild disease with a completely normal fibroscan and really no particular risk. And if we could at least streamline the clinical care pathways, that everybody who takes care of an individual at risk for diabetes or with several cardiometabolic risk factors would screen for liver disease once in a while, particularly if you have more than one risk factor, because we know it's additive and synergistic, and then have these clear referral pathways. That would already be a huge plus if we could achieve that. And I agree with Elisabetta, it's important that the liver is one aspect of the management by everybody who takes care of these individuals. And in the end, if they have cirrhosis, I guess hopefully they will be referred to the liver specialist anyway, because that is probably a bit too much to manage for somebody outside the hepatology specialty. But that will be hopefully only a fraction if we detect early enough and kind of counteract those risk factors.
That's great, Frank and Elisabetta. A thought and a question. Okay, the thought comes from Ken Cusi, whose comment was that in diabetes, if we check the eyes once a year and we check the kidneys once a year and we check neuropathy once a year, why wouldn't we check the liver once a year? Which seems a pretty simple way to stay on top of things. Okay. The other thought was a little more complicated. Having had some experience recently with cancer and tumor teams, I'm struck by the idea that groups of multiple disciplines get together once a week at an oncology center to figure out holistically what to do with each patient. But there are far fewer patients with cancer in any one cancer center than we're talking about here. So I'm wondering, is that an appropriate way to handle patients with cirrhosis? Is that an appropriate way to handle patients once they hit some threshold of risk factors, whatever they are? Or is that just a little too idealistic to think we're ever going to get to? Or is there a fourth option?
I mean, we have those cirrhosis boards in the pre-liver transplant setting. And of course, there, like all aspects of the individual's health is being discussed at great depth and very meticulous granular examination on all aspects of health. I'm not sure it's realistic for like the whole population of maybe even advanced fibrosis, because there are just too many. I think if we can come up with clear guidance on the management, that would be already a huge advantage, and identifying this silent population of individuals with already advanced fibrosis, so in a really high risk situation of developing this, would be very, very useful. And maybe technology will help us. Maybe at some point, I don't know, sequencing the whole genome will be €100 or so, $100. Then we may be able to identify more factors that would give us a better perspective on individuals' risk, or maybe pathways that we could also target therapeutically.
Interesting thought. Elisabetta, anything to add?
No, I'm I'm excited to see how places like Australia, obviously where I work as well, will take to these guidelines, because things like FibroScan aren't on Medicare, so they don't have access to the non-invasive technologies that we do in Europe. I know they're keen to look at the nice guidance of putting non-invasive technologies like VCTE into primary care and how that's going to go. So it'll be interesting to see how these nations and other parts of the world reference these documents, which are by far the latest thing. So I'm looking for how wide your spread is going to be from the documents and the process, because the process is thorough. You've covered the ethnicities and that. I'm looking forward to seeing you. I think you could span the world.
If I can make one last comment. Document looks good. I can say that we did a good job. The problem is if people is going to read it. So awareness is always the key, because you can have the best guidelines in the world, but if no one is reading, if no one is taking into account this disease, then it's useless. So, spreading awareness is very, very important.
I couldn't agree more. I do have one more question. This is about the future, right? Which is that at this Congress, at the same time that these guidelines were revealed, we had 5 or 6 major phase 2B drug studies, and we had the special trial, which suggests that bariatric surgery in a cirrhotic patient has an astonishing 10-year risk reduction rate. I think it was 0.28 on mallow and 0.2 on decompensation. How do you intend or hope to help these guidelines keep pace or stay close as the rate of technological knowledge and drug improvement and device improvement, frankly, just amplifies and gets faster and faster and faster? How do you see that happening?
Yeah, I'm not too pessimistic, because in the end, to recommend, for instance, tirzepatide or survodutide as a MASH-targeted therapy, we would need the phase 3 clinical trial data. I think there is no other way that this would get approved based on the phase 2B study that we have seen. So we have already, I think, implemented a lot of words that open the door quite wide, that we say, okay, if you have a reason, an indication like type 2 diabetes, obesity, to prescribe co-agonists or GLP-1 receptor agonists, do it in the patients, but don't prescribe it as a MASH-targeted pharmacotherapy. Regarding bariatric surgery, I think we already recommend this in class 2 and 3 obesity, so BMI above 35 or BMI above 40 in the population of MASLD, that it should be considered. For the cirrhotic population, I think our recommendations are also quite proactive, because we do not say, oh, it's contraindicated in cirrhosis, as many guidelines have done this before. We open the door quite widely to say, okay, consider if there is portal hypertension, history of decompensating events or anything, and then do it at a center that is very much qualified for this. And I think based on the data that were very impressive from the Cleveland Clinic and the success of bariatric procedures in individuals affected with compensated cirrhosis, I would say I would come up with the same recommendation. So I guess the evidence that is there is included as much as possible. I don't think that every center who does, 5-6 procedures per year should do this in an individual with compensated liver cirrhosis. That would be probably quite risky. But in experienced centers, I think even bariatric surgery is an option for patients with compensated liver cirrhosis.
Thanks, Frank. And do any of you have any comments or questions you want to add at this point? We've been doing this for frighteningly close to an hour, and I think it's time to wrap up.
I think very important, if you want to download the guideline, go to the Journal of Hepatology website and download it. It's for free. It's open access. So we have been talking about it for quite a while. There's also an app by EASL where the guideline is implemented. I think that the document is a PDF. You can download it. Yeah, and feel free to do that.
We will actually have the link to the article in the write-up when we put this podcast up. If you send me the description of the EASL app, I'll put that in the write-up also as well. Because I agree, we would like to see these distributed as widely as possible. That's why we wanted to make sure to do this episode so that we could help. Congratulations on an amazing piece of work, folks. As I say, Louise and I were smiling at each other, virtually grinning like idiots as we were going through this. The moment that hit us was resmetirom, and then we went back and thought about it and said, boy, it's all that good, isn't it? So congratulations. Really fantastic. And I look forward to having both of you back on the podcast for other subjects in the years to come. I'll be back in a minute with Question of the Week and the business report. Right now, everybody say goodbye.
See you.
And now, here's Roger with this week's Question of the Week.
And here's this week's Question of the Week. This week's episode discussed the new clinical guidelines from EASL, EASD, and EASO. Based on today's discussion and the guidelines, which I recommend you read, How readily do you believe these guidelines will be implemented? And which sections will be easiest to implement? Which hardest?
And now for the Season 5, Episode 21 Business Report.
Slava Ukraini, glory to Ukraine, Heroyam Slava, glory to heroes, and also Am Yisrael Chai, the people of Israel live. In Ukraine, in the past week, President Zelensky announced that Ukraine completed its preliminary filing to join the European community. Anything that provides more unity and protection for the Western democracies sounds great to me. Let's stop for a minute to remember and respect the brave Ukrainian fighters and residents. In Israel, nothing much this week to add. Let's remember and wish for the safety and the speedy return of the many remaining Israeli hostages. Remember and pray for safety for the Gazan residents whose needs are poorly served by their government's approach to the situation, and hope that the people of Israel and Gaza can be led in the near future by governments that truly, not just rhetorically, have their best interests at heart. Heroyam Slava, glory to heroes, and also Am Yisrael Chai, the people of Israel live.
Our month of lessons from the EASL Congress continues.
Thanks to Elisabetta, Frank, and Louise for a fantastic discussion today on the updated EASL-EASD-EASO Clinical Practice Guidelines. We had a few more tech devils than usual, which is why Luca Valente and Jorn were unable to join. Still, a fascinating session about some truly impressive guidelines. If you've not read these yet, click the link in any of our episode write-ups to find them. Next week, Jeff Lazarus joins us to discuss the Healthy Liver, Healthy Lives initiative. And in 2 weeks, Shiraz El-Barsagi, Mike Patel, patient advocate Jose Willemse, and UK physician Tip Margett are joining us to discuss their well-received session from EASL on the challenges that patients face in having their messages heard in the healthcare system. We anticipate at least one more week of EASL follow-ups, maybe 2 after that.
Our month of lessons from the EASL Congress continues.
If you're one of the now 600 members of our Surfing MASH community, check last week's newsletter for the link to the Healthy Liver, Healthy Lives episode, which records at 9 a.m. Eastern Daylight Time in the U.S. on Monday morning. That's 3 in the afternoon in Central Europe, 2 in the afternoon in the British time zone, 8 in the morning in the Central time zone U.S. We do not believe we had any live audience last week. We look to build this back up over time, and people who were in our live audience when we had it in years past can tell you it was interesting, and several of them even came in and asked questions, which was just great.
Office hours start Wednesday, July 10th at 11 o'clock Eastern U.S. time.
Our first week of weekly office hours will start on Wednesday, July 10th at 11 a.m. Eastern Daylight Time, which is 5 p.m. Central Europe, 4 p.m. in the British time zone, 10 a.m. in the Central U.S. time. I will publish the Google Link Meet for these office hours in next Monday's newsletter and every week thereafter.
This week's Vault comes from last year's review of the AASLD Clinical Guidance.
In February 2023, the AASLD published a document described as a clinical guidance, an update of a 2018 document that has suggestions but not formal guidelines. In this conversation from the following week, Ken Kuzi joined us to discuss the ways the AASLD document was likely to be used in the construction of the EASL guidelines and perhaps for NICE in some of their research and decision-making. It's a different spin, but totally worth rehearing. So that's it for this week. I want to thank our team, Jorn, Louise, Mike, Eric, Steve, as we keep moving forward. Please take a listen to our question of the week and, of course, reply. If you're a LinkedIn follower, or check your in-mail or messages for an invitation to subscribe to our weekly piece. And if you get the newsletter, check it if you want to join us live next week. We'll be back next week, as I said, to discuss Healthy Liver, Healthy Lives. Until then, stay safe, surf on. See you on podcast. Bye-bye now.
Have any questions for the surfers? You can send them to questions@surfingmash.com and we will answer on the podcast or website. Your question might even wind up being the question of the week.